This session will have three speakers joining us. Two are cardiologists and one is endocrinologist. Lately, the drug that using in the diabetes turn out to be the cardiac drugs, because we understand that the new drugs coming, like the SGLT2 antagonist and the GLP-1 receptor agonist, more or less is like a cardiac drugs, because it's reduced cardiovascular events quite huge. And in some categories, people who have no diabetes might use these glucose lowering drugs. So we are quite lucky to have Professor Lale Tokiosoro, if I spell your name correctly, who is a professor of cardiology at the Hacettepe University, Ankara, in Turkey. Please welcome Professor Lale.
So I'd like to start by thanking Professor Jean-Charles and Dr. Jamila Fouchard for their kind invitation. It's been a privilege to be a part of this, what I will call a scientific feast, and I truly enjoyed the discussions we had yesterday. So what I will try to do is give you the perspective of the cardiologist in terms of glucose-lowering medications. Here you can see my disclosures. Diabetes is a major health problem with its prevalence increasing all over the world. And if things go at this rate, the predictions about the population of 700 million having diabetes in 2045 is really scary. Cardiovascular disease is the leading cause of death in patients with diabetes, and more than a quarter of asymptomatic diabetics will have subclinical atherosclerosis when screened. We also know that heart failure is 2 to 4 higher and leading to hospitalizations in patients with diabetes, with significantly increased risks of peripheral arterial disease as well as stroke. For this reason, it's important to lower cardiovascular outcomes in these patients. However, trials with intensive glucose lowering have failed to convincingly demonstrate that cardiovascular events are decreased in these patients, with some decrease in non-fatal MI in this large meta-analysis of 33,000 patients. For this reason, for years, we tried to make up for this by lowering LDL cholesterol more aggressively and trying to get to blood pressure goals to decrease cardiovascular events. But we know that even if you control the LDL cholesterol and blood pressure as much as you can, there's still remaining major cardiovascular related risk in patients with diabetes. So we really need to do better. Metformin has been our friend and first-line treatment for several years due to its efficacy, safety, duration of the evidence, affordability, and limited side effect profile for years. And most of the data we have relies on the old UKPDS trial, which excluded patients with heart failure and acute coronary syndromes. So the number, size, quality of randomized trials of metformin led to some uncertainty about their cardiovascular reduction. There is a meta-analysis of 13 trials with only 2,000 patients showing that all outcomes except stroke favored metformin, but none achieved statistical significance. As you all know, there was a paradigm shift in 2008. Before that, all drugs were approved according to their glucose-lowering properties. But after the scare of increased heart failure with glitazoles, FDA-mandated cardiovascular outcome trials for all the novel anti-diabetic agents, which really started changing the landscape. Then came the incretin-based therapies, which inhibit the degradation of incretins. And first group was the DPP-4 inhibitors. And they have been tested in 5 large outcome trials for cardiovascular endpoints. And here you see the meta-analysis of SAVOR, TCOS, and EXAMINE, 3 huge trials showing that major cardiovascular events were neutral. So the type of drugs were safe, but with no major cardiovascular benefit. And in Saxa and alogliptin trials, there was some increases in heart failure. The second group of S-incretin-based therapies, the GLP receptor agonists, are more potent, and they have several positive effects, including augmenting glucose-dependent insulin secretion and glucagon suppression. They prolong gastric emptying, induce satiety, they cause weight loss significantly, and activate the metabolism of brown fat, increasing energy expenditure. Their effects go well beyond glucose control because their GLP-1 receptors in the brain, heart, liver, pancreas, and the GI tract, which may explain some of the pleiotropic effects we see with these agents. But we're mostly interested in the anti-atherosclerotic effects, some statin-like and some unlike. They improve endothelial function, decrease vascular smooth muscle activation and proliferation, decrease vascular inflammation, decrease LDL cholesterol and lipid accumulation. They also have favorable effects on blood pressure, weight, and hemoglobin A1C. So all of these properties make them very good candidates for cardiovascular reduction. And in the SELECT trial, they're being tested for patients without diabetes as well. They vary in molecular structure and size, mainly due to the fact that the native human GLP-1 has a very short half-life. So it has been possible to manufacture extendin-based therapies or human GLP-1-based therapies. Extendin is a reptile protein sharing about 50% amino acid sequence homology to human GLP-1. And here you see the large number of trials with extendin-based therapies as well as the human GLP-1-based therapies. Will this make a difference? We still have to see. Most of these agents are given subcutaneously, and some are shorter and some are longer acting. There are several differences between them, including the fact that there are large fluctuations in plasma peptides with the short-acting ones, but they have the advantage of controlling postprandial excursions better. So it's possible to tailor the drug according to the patient's needs. The landmark trial with GLP-1 was the LEADER trial looking at liraglutide and cardiovascular outcomes in more than 9,000 patients. And liraglutide shares about 97% sequence identity with the human GLP-1. And this trial showed that there was a significant decrease in 3-point MACE with liraglutide, showing superiority over placebo. Deaths from cardiovascular disease were decreased, and although not statistically significant, there were fewer hospitalizations for heart failure. Here you see the major cardiovascular outcome trials with GLP-1 receptor agonists. And here you see that the median follow-up time was rather short with them, except for REWIND trial. Most of these were middle-aged, overweight. Most of them were already taking metformin. About 20% of them had GFR below 20. And you see in most, but not all of them, reductions in 3-point MACE. And here again, you see that 4 structurally similar to human GLP-1 and 1 extended-based therapies have shown superiority over placebo, the most recent one being the Amplitude-O trial. When a large meta-analysis, including about 60,000 patients, was performed with all these trials, there was a 14% reduction in MACE. The lira-sema-albumin dulaglutide, the longer-acting ones, but not exenatide or lixenatide, were superior to placebo, and only liraglutide reduced cardiovascular and all-cause mortality. Here you see the components of MACE, and you can see that all were going in the right direction. The most outstanding one being the decreases in fatal or non-fatal stroke, with an overall 12% decrease in cardiovascular death and mortality. A large meta-analysis also looked whether they were just as beneficial in primary prevention, because secondary prevention patients had the higher risk and higher risk reductions. And initially, it seemed as if primary prevention patients did not benefit as much. But we have to keep in mind that a long follow-up is necessary to show the benefit in primary prevention. And the REWIND study, the one with the longest follow-up, showed us that there was indeed cardiovascular benefit. And this is important because there are a lot of patients with diabetes who have probably subclinical atherosclerosis. So overall, the GLP-1 receptor agonists have positive effects on cardiovascular outcomes, lower glucose, weight, and blood pressure. They do have side effects such as gastrointestinal problems, local reaction at injection sites, and we've also seen that they do increase the heart rate, which may not be so beneficial. And the patient profile most likely to benefit is the one with pre-existing atherosclerosis, overweight, obese, with a high risk of stroke. And also their dual or triple peptide agonists in clinical development that probably Dr. Sharma will talk more about. But tirzepatide is the one that has been FDA approved now, and it's a dual GLP-1 and GIP agonist. And it has very important, strong effects on hemoglobin A1C, but also weight reduction. The second group of major group of drugs that have been tested for cardiovascular outcomes are the SGLT2 inhibitors, increasing the urinary excretion of glucose in proximal tubules. There are 4 FDA-approved SGLT2 inhibitors. EMPA-ER2 are the most selective for SGLT2, and canagliflozin the least selective. The newcomer in the field is sotagliflozin, which provides dual SGLT1 and SGLT2 inhibition. There are several mechanisms proposed for their cardiovascular benefit. They decrease the pre and after load, improving ventricular loading conditions, improve cardiac metabolism, inhibit myocardial sodium-hydrogen exchange. One important aspect is that they reduce necrosis and cardiac fibrosis, which may reverse the remodeling that is associated with diabetes-associated problems. They alter adipokines, cytokines, and epicardial adipose tissue mass. They do decrease uric acid, do not decrease LDL, but decrease small dense LDL, triglycerides as well. EMPA-REG outcome was the most important trial, the first one to show that empagliflozin reduces cardiovascular outcomes as well as mortality in patients with diabetes. Tested in more than 7,000 patients, the primary outcome of cardiovascular death, non-fatal MI, and stroke decreased, mostly driven by the reduction in cardiovascular death, with no significant decrease in MI or stroke. And there was significantly lower risk of death from any cause plus hospitalization for heart failure. And when we look at the SGLT2 cardiovascular outcome trials in diabetes, the follow-up ranges from 2 to 4 years, mean age similar to the GLP-1 trials, overweight patients, most of them taking baseline metformin. And the main finding here is that they decrease cardiovascular death or heart failure hospitalization significantly. There is some discrepancy, maybe due to the baseline characteristics or the duration of the follow-up or due to the patient differences. But although they all consistently reduce heart failure hospitalization, cardiovascular death has been decreased only in the EMPA-REG with empagliflozin and MACE both in EMPA-REG and canagliflozin programs. When you look at the meta-analysis of MACE, overall there's a 10% reduction in MACE, but it was shown only driven by EMPA or canagliflozin. It doesn't seem to be different by the status of presence of atherosclerotic vascular disease or not. And cardiovascular death is reduced by 15% with some heterogeneity. Will adding SGLT1 inhibition benefit to SGLT2 inhibition in prevention of cardiovascular outcomes in diabetes? And this is a question that is being asked. The main reason being that SGLT1 inhibition delays the intestinal glucose absorption, but also reduces left ventricular hypertrophy and fibrosis, which may be a potential problem in these patients. And the greater reduction in MI and stroke with sotagliflozin in the soloist and SCORED compared with SGLT2 inhibitors may relate to this increased inhibition of GLP-1. Here you see the heart failure trials that have been conducted with SGLT2 inhibitors. The soloist only recruited patients who were hospitalized inpatients for heart failure, and outpatients were tested in the remaining trials. You see that a large spectrum of ejection fractions have been included in these trials, with EMPA-reduced and DAPA heart failure looking at patients with reduced ejection fraction only, whereas in the EMPA-preserved and DELIVER, there were patients with preserved ejection fraction. The consistent thing about SGLT2 inhibitors is that they cause a dramatic 31% relative risk reduction in heart failure hospitalization that has been consistent across different trials. Now, the heart failure with preserved ejection fraction is a main problem, and we're seeing it increasingly worldwide. The population is aging, the hypertensive diabetic patients are surviving more, as well as patients with coronary artery disease. So now in the clinic, we tend to see patients with preserved ejection fraction heart failure even more than patients with reduced ejection fraction. And for all the reasons summarized here, diabetes is a frequent cause of heart failure with preserved ejection fraction. And until recently, we did not have anything to treat these patients specifically. So EMPEROR Preserved was an important trial because it looked at about 6,000 patients with class 2-4 heart failure and randomized them to empagliflozin or placebo. And as you can see here, there was a 21% low risk in cardiovascular death or hospitalization, and about a 30% low risk of hospitalization for heart failure. And this is the first drug now to be recommended for patients with preserved ejection fraction. Professor Braunwald very aptly named SGLT2 inhibitors the statins of the 21st century because of all their positive properties. Of course, we have to keep in mind that there are side effects related to this, And when personalizing therapy, we have to keep in mind that they increase genitourinary infections, especially prolonged starving can lead to diabetic ketoacidosis. The risk of amputations, fractures, and volume depletion is there. So which one is better for our patients in terms of cardiovascular protection only, SGLT2 or GLP-1? Of course, there's no head-to-head comparison or randomized trial looking into this, but there's some network meta-analysis. There was one which enrolled patients up till the trials that completed in 2020 and also divided them into different risk groups, trying to compare their efficacy on cardiovascular outcomes. This specific meta-analysis concluded that both are effective for all-cause cardiovascular non-fatal MI, but for non-fatal stroke, GLP-1 receptor agonists were better, and for heart failure hospitalization, SGLT2 was better. But of course, the absolute benefits varied substantially across patients from low to high risk. So both of these decrease MACE, nephropathy, and weight. Why don't we combine both of them? Is the question, of course, if you can afford it. GLP-1 receptor agonists mainly affect the atherothrombotic process. SGLT2 inhibitors affect the outcomes more rapidly than GLP-1, with a more pronounced effect on heart failure. So maybe we can get some therapeutic synergy by combining these two classes. And of course, there's no randomized trial looking at it, but there's some post-hoc analysis and one pre-specified analysis from trials. So in the Excel trial, some of these patients got both GLP-1 and SGLT2, and they did indeed fare better in terms of cardiovascular death. But of course, we have to be cautious about post-hoc analysis. So how has this been reflected in the guidelines? The European Society of Cardiology, together with EASD, did a dramatic change in its guidelines, and for patients with type 2 diabetes not yet taking a drug, if they did have atherosclerosis or were at high risk of cardiovascular events with target organ damage or multiple risk factors, they were first to recommend to start with SGLT2 or GLP-1 monotherapy and then add metformin. But for the remaining group of patients, metformin still would be the therapy of choice. And if it was not enough to control, then all other agents could be added. And this went on for a while, but there are also specifications about the choice of drugs, saying that if you want to reduce cardiovascular events, prefer empagliflozin or dapagliflozin, and to prevent cardiovascular death, empagliflozin, if you're using an SGLT2 inhibitor. If you prefer a GLP-1, then lirasema or dulaglutide are those to be used to reduce cardiovascular events, and lira to reduce the risk of death. And all of them have been given a class 1, which is a strong recommendation, with all others to be used as combination therapy if necessary. There have been arguments against the use of our old friend metformin first in patients with type 2 diabetes who have atherosclerotic vascular disease. And the reason for this is that the robust evidence for metformin decreasing cardiovascular benefits is lacking. And the cardiovascular outcome trials with these new agents had similar benefits regardless of the baseline metformin or not, and trying to decrease the number of agents as well. So these arguments are going back and forth. And the new 2022 consensus by the ADA and EASD is reflecting these ongoing arguments. It's a very holistic and personalized approach of type 2 diabetes management recommended in this new consensus paper, focusing on social determinants of health, physical activity behaviors, including sleep, as Professor Lippi recommended. And there is greater emphasis than ever on weight management, with the population becoming overweight. So in addition to cardiorenal protection, which we should really consider, managing all the other cardiovascular risk factors, weight and glucose, should all be considered together, also taking into consideration the patient preferences and the cost. So this new consensus paper is recommending that if the patient has atherosclerotic vascular disease or indicators of high risk with several risk factors, then either a GLP-1 with proven benefit or SGLT2 with proven benefit should be the first choice. And it also goes on to say that if we're above target, the second choice should also be either one of these. If the patient has heart failure, then SGLT2 with proven heart failure benefit in this population needs to be started first. But of course, we can't only go on cardiovascular outcomes. We have to control the glucose as well. And the new consensus really highlights the fact that some drugs have higher efficacy for glucose lowering. So the very high glucose lowering agents, dula, semaglutide, tirzepatide, should be thought of first when you are trying to control the glucose. And if already on insulin, instead of increasing the insulin dose, they're recommending to combine with a GLP-1 receptor agonist. And also, weight loss is given high priority with the two agents that are more effective for weight loss being sema or tirzepatide. So this guideline, and all we know is summarizing that we really need to take a multifactorial approach to decrease cardiorenal risk in our patients and not just focus on one area. So there are four big pillars of diabetes management: glycemic, blood pressure, and lipid management, but also take into considerations agents with cardiovascular and kidney benefits. Having said that, what's happening in real life when, if you look at the CAPTURE study done in 13 countries, only 2 in 10 of patients with type 2 diabetes are receiving these agents with a proven cardiovascular benefit. Of course, cost may be an issue here, and there are several other reasons for it. And we cannot expect everyone to be first on these agents, but I think we may increase usage of these agents in our clinical practice. So I'll stop here, and I'll be happy to answer any questions. Thank you.
Thank you very much for your brilliant presentation.